Hey everybody, so we are here in our clinic. We got Kelsey, and what we want to do today is take you through a TMJ occlusal exam. We're going to have Kelsey be the patient. And again, I want you to pay attention to a couple things from the standpoint of maybe the efficiency of it a little bit, but what I also want you to be thinking about is that when we're doing a TMJ occlusal exam, that we are doing an analysis of each part of the system. So we're thinking about the temporomandibular joint, we're thinking about the muscles of mastication, and we're thinking about the teeth. And remember, if there's an occlusal problem, for whatever weak link exists in the patients, they can have a problem with any one of those parts of the system, or all parts of the system, or not any part of the system. And so we make strategies or workflows for our patients based on what we see. So if there's no occlusal issues at all, that's a patient that we can work with in maximum cuspation. If there's problems with the muscles or the teeth, then we'll employ Dr. Dawson's 5 requirements of occlusal stability and design an occlusion appropriate for them. And then if there's problems with the joint themselves, then we have to get the joint stable prior to doing anything to the teeth, or at least the occlusion. And so let's sort of go through this, and I also want you to notice that when we're doing this, we're sort of starting on the outside of the body and working our way in. And so that way we only sort of glove up one time, and we're not coming in and out. So I'm going to go back and forth to my computer over here. And so to be clear, we just want to make sure that everybody that is coming in, we are doing an appropriate TMJ occlusal exam. So we're going to start with Kelsey and just ask her basically some 7 questions. So first of all, have you ever had or been diagnosed with any problem with your temporomandibular joint?
No.
Okay, so no. Any pain or on opening, closing, or chewing?
No.
Okay. Popping or clicking?
Sometimes.
Okay. What's that like? When does that occur?
Not that often, but sometimes I can pop it in and out.
Okay, okay. How about headaches?
No.
Okay. Any history of trauma?
No.
Okay. So, first of all, a lot of the questions that we get into with our patients with regards to diagnosis, any history of trauma, any previous diagnosis with TMD, what I can tell you is that if they have no noise, no awareness of popping or clicking, if they have no previous history of TMD, if they have no pain in and around the joints, if they don't have a lot of headaches, the chances are that this is not a patient with a TMJ problem. Now, she did say that she has occasionally a pop or a click. And as you know from listening to Dr. Maddie, that can mean that that little disc is just starting to change position. So we want to see if there could be an occlusal component later in the exam that could be causing some hyperactivity of the lateral pterygoid that could be pulling the disc out of position. So that's the only thing in the history that really concerns me at all. The second thing that I'm going to do to look at the joint is I'm going to look at the range of motion and the path of motion. And if you remember, when we do range of motion and path of motion, we should be seeing about 40 millimeters. Too strong here. We should see about 40 millimeters on opening, and we should see about 10 millimeters in protrusion in left or right. And beyond the amount, we also want to see that the path is nice and straight. We don't want to see deviation. So let's just look at her before we measure and sort of see. So Kelsey, just open straight up, close, open, close, open. That looks nice and straight. We're going to close about halfway now. Now go left as far as you can go, back to the right as far as you can go, and go forward as far as you can go. That looks pretty darn good. So this is our little card that we utilize. We get it from Great Lakes, and it's kind of slick because there's this little notch in it, and we can put this on the lower incisors and have her open and roll it over. And she's opening about 50 millimeters, bite down, and we need to add the overbite. Open a little bit. She's probably got 4 or 5 millimeters of overbite. So she's opening 55 millimeters, which is absolutely great. And then the other thing for left and right lateral, you can put this, open a little bit for me, right on the lower incisor midline, bite down, and go to the left as far as you can, and back to the right as far as you can, And again, you can get an idea that she's going past 10 millimeters. In protrusion, it's pretty simple. We're basically going to put this spike down. Look at her overjet, which is about 3 millimeters, and then put this against her centrals and go straight out. And again, she's going past 10. So if I have somebody that is going over 40 millimeters on opening, and they are going past 10 in protrusion, right or left lateral, then that is normal range of motion. What I want you to visualize is this, is if you have a patient who's off the disc on one side or has a derangement, the thing that I want you to remember is the chin is going to point to the affected joint. So if she were to have a disc problem in this side and it's problematic, what you'd expect is that the left side would rotate and translate normally. This side would not be able to, so she would open something like this. It would deviate to that side. Sometimes you'll see people that start sliding over and then you'll hear a click and then they come back. And what's happening is, as the condyle starts to translate, the disc is in front of the joint, and when it pops back on, it comes back around. So understanding the basic dynamic movements of the joints are important. And you can often, just from a history and from an analysis of the joint itself, the range of motion, get a pretty good idea of what is going on. All right, so we're going to look at the joint unloading in a second when we start putting our hands on her, but the next thing we want to do is look at muscles. And again, one of the things you'll notice about Kelsey is she does have pretty good size masters, and so when you've had a history of clenching can cause muscles to get a little bit bigger. It also loads the joint, so maybe there's some minor occlusal things going on that could be affecting that joint. Okay, we didn't have any history of headaches though, right? Okay, so sometimes you might pick up some of the issues just from palpation, from things being sore. We're going to palpate basically the master, the medial pterygoid, and the temporalis. And again, depending on who you talk to, there's a little bit of a debate about whether you can actually palpate the lateral pterygoid. But I'm going to show you a way that we can still activate the lateral pterygoid. But we're going to be looking at the muscles of mastication in our screening. Okay, so let's look at it. And I'm just going to stand up to do this so that you guys can see. But let's just start with our master, and remember that our master, we think about origin and insertion, that muscle's sort of coming across her face like this. And the best way to palpate is you can support your hand on one side and bring your fingers across the muscle. Just let your teeth separate a little bit. And what I'm looking for are little tight tenderness bands. Is that a little sore right there?
Yeah, a little bit.
Yeah. I can feel a little kind of a knot, almost like if you had a Charlie horse right there. Of course, that's right where there's a little hypertrophy. About the left side. A little bit right there.
Yeah, a little bit.
Okay. All right. So we would be asking her if 0 is no pain and 3 was extreme pain. What would you say? Kind of 1.5-ish?
Yeah.
Okay. Now we're going to go up and look at the temporalis. Remember, the temporalis is a big fan-shaped muscle. And again, sometimes if you have the patient clench, it can help you get oriented. So clench a couple times. Okay, you see my fingers moving? This is often a place that when people get headaches can be sore. So I'm going to go about 2 knuckles off the lateral canthus of the eye, about right in here.
Yeah, center.
Yeah, a little sore in there. This one in here a little bit.
Mm-hmm.
Okay. All right. So now we're going to do medial pterygoid, and this is when we can start going inside the mouth. And remember where the medial pterygoid is, that the pterygomandibular raphe, that one of those areas that you think about when you're doing a block, just distal or behind the pterygomandibular raphe is the medial pterygoid muscle. In other words, the anterior border of the pterygomandibular raphe is the medial pterygoid. So if you put your finger back on the tuberosity and slide around the pterygomandibular FA and push laterally, you're pushing on the muscle. So what we're going to do is go back on the tuberosity. I'll feel that FA. Open real big, Kels, right there. That sore at all?
Mm-hmm.
Okay, good. Right, medial pterygoid's clear. And if we go over here, how's that? Teeny bit?
Yeah, teeny bit.
Okay, great. All right, so we'll make a note of that. Now the last one's the lateral pterygoid. And again, I've heard people say they put their pinkies up there. You have to remember when you're trying to get to it, there's also there's insertion of the temporalis muscle and the cornoid process. There's the master. There's all sorts of things. So I like to think about the lateral pterygoid being behind the eye. And so what I'll have the patient do is I'll put my thumb on the patient's chin, and I'll have them push against so kind of protrude. Do you feel any burning sensation behind your eyes? No? Okay. So in a protrusive stroke, remember your origin insertion of the lateral pterygoid. It's grabbing onto the neck of that condyle, and it's responsible for protrusion. So if she can protrude with his resistance without any pain or discomfort, then we probably have a clean lateral pterygoid muscle. Okay, so when we look at her, we're seeing a little bit of temporalis pain, a little bit of master pain, but the muscles that sort of responsible for the AP positioning seem to be clean. A lot of times what I see is when patients have more master and medial pterygoid pain, is it's more related to just isometric clenching. And she is a new dentist, so she may be doing some clenching here at work. I would not be surprised, a little more stress. But it also could be related to the occlusion. All right, so we're going to look for that. All right, so now what we're going to do, the last piece to really look at for the joints is to do our load test. And with our load test, we're going to use Dr. Dawson's bilateral manipulation. And the theory of the load test is if I can put pressure on the joints, orthopedic loading of the joints, and she doesn't have any sign of tenderness, then we can surmise that the condyle disc arrangement is all in proper alignment. If we were to load her joint and she had pain, then what we'd be thinking about is the disc is probably displaced forward and the condyle is impinging on that highly vascular, highly nervated retrodistal tissue. So that's the first part of it. The other part of it, remember, is seeing if there's a discrepancy between the patient's centric relation and their maximum intercuspation, that if there's a slide there. Sometimes if there's a slide, that can be the thing that contributes to wear. It can contribute to the muscles being sore, and it can contribute to some of the little joint changes that are going on. So what we're going to do is to remember is when we do this load test, we are going to do this in a way that allows the patient's jaw to relax. In other words, we're not going to force the patient there, but we're going to do this in a way that allows the patient to relax and for the jaw to kind of go back by itself. And then once we think she's hinging and centric, then we'll apply the load. Okay? So let's just do this. So first thing we're going to do is just bring her chin up a little bit. And I'm going to get my 4 fingers on her jaw. And I'm just going to very gently just have her open and close. Slowly open and close. And make sure the patient's teeth are not touching when they're doing this. The idea is they open and close, the mechanoreception or the proprioception from the teeth starts to wash away, and the condyles can start to seat. Lateral pterygoid releases and the condyles start to seat. All right, stop right there, Kels. I'm going to put my thumbs in position now. She feels like she's hinging, and I'm going to start my loading by just putting a little bit of pressure down with my thumbs, up with my pinkies, and creating a vector force that loads that joint. So I'm going to first put just a little pressure here. Tell me, do you have any sign of tension or tenderness in either joint?
Some tightness up here.
A little bit there? Okay, so just a little bit of tightness at that first increment. So let's just give her a little bit more time to just open and close. Now in the practice, at this point, we might go ahead and even put a deprogrammer in there and let her sit for 10 or 15 minutes. or a couple cotton rolls. Remember, separating the teeth takes away the mechanoreception and allows the muscles to relax. Just keep going here, Kels. So she's got tightness on this side. What I'm thinking about, so it wasn't pain, it was sort of tight, that maybe that lateral pterygoid just hadn't completely released over here. It's feeling like it's a little better. Let's try again now. What I'm going to do is consciously try to just romance that condyle back a little bit. All right, right there now. Let's try that. A little pressure, any tension or tenderness there? Okay, that's good. We're going number 2. How about there? How about there? Okay, 3 increments now. Now what I'm going to do is hold her condyle there, and then I'm going to close her, and you tell me what you're touching first. Slowly down. Probably somewhere in the back. Where are you hitting? A little bit on the right side. Okay. So I'm going to touch. Now squeeze. Yeah. So let's watch. She closes. Her. All right. Start again. All right, so what we're doing is holding this in centric. We're closing that first point of contact. Now squeeze, and there's that slide, little slide. Here's centric relation position, and then she slides into MI. So believe it or not, that little slide between CR and MI is the thing that can cause some issues with the muscles that she's feeling, maybe that early joint change. And then the last thing we're going to look at in the mouth is at the teeth themselves. So remember, when we're thinking about examining the patient's teeth, there can be wear, all right? That's very obvious when you're paying attention to it. There can be mobility in the absence of periodontal disease. If a tooth is loose and there's no bone loss around it, there's only one cause, and that's that it's getting hit too hard. It's occlusion. And then the third thing that can be a little bit more difficult with a new patient is teeth that are migrating or shifting position. So what you have to pay attention to when you're looking for migration is look for diastemas. And if there's a diastema, ask the patient, has the diastema or space always been there? If it hasn't, the teeth are not stable. Okay, so changing tooth position is usually an occlusal issue. With regards to the analyzing the dentition, you're going to want to put on your loupes, and if you just have a tooth chart where you can circle the teeth that are having some issues, first thing I'll look at is wear and tear. Kelsey has maybe a little teeny bit of wear on a lateral right here. A little bit of wear on some laterals up top. Okay. Next thing we'll look at, I don't see any diastemas. There's no spaces that you're aware of, right? Okay. And then the last thing we're going to just check is mobility. And we're checking for mobility. It's really important to use something rigid like the back of a mirror handle. Don't use your fingers. Use a mirror handle. If you can use 2 mirror handles, it's even better. And you want to push in a buccal lingual direction or a lingual buccal direction. You start doing this, you're going to be shocked how many loose teeth there are. Okay, so that's pretty much it with our screen. So we've done a little bit of a history. The only thing that was positive was a little bit of clicking. Everything else was clean. We palpated some muscles, and we had some concerns over the palpation of her temporalis and master muscles. Her range of motion was completely good. Notice with our load test, she had a little tightness initially because that lateral pterygoid was sort of holding the jaw forward to reach the patient's maximum intercuspation position. And again, when we look at the load test itself, though, we were able to seat the joint. We don't have any issues with any kind of disc displacement or anything like that. And we do see a little bit of wear. So when I look at Kelsey, I kind of think about our three types of patients. There's the patients with a negative occlusal exam. There's a patient with a positive occlusal exam that's related to muscles and teeth. And there's the patient that has a positive occlusal exam related to the joint. She falls in that middle category. And so what would be next for her would be to do some advanced records. We'd take some photographs of her teeth, we'd take a face bow, we would take a bite record, we'd take some impressions, and we would study her occlusion by looking at how the teeth actually line up in centric relation, so we can just to see what we would have to do to create that centric occlusion, which, as you know, is when the teeth, when maximum cuspation and centric relation is the same. You know, if we can do that, then we should be able to really kind of turn the thermostat down in the system, slow down the wear, make her muscles more comfortable. And so I want you to really think about that. That is the concept that there are going to be patients that you absolutely can appropriately work in the patient's own habitual occlusion, sort of regardless of how it looks like, because there's no occlusal disease. But you're also learning some strategies that are going to work really, really well for you when you start seeing some patients that have a little bit more difficulty, whether it's a worn dentition case or veneer case or implant cases. That's when we have to redesign the occlusion. Just remember, it starts with a good, thorough exam. And once you get that data, then you can start having appropriate workflows for each type of patient. So I hope you enjoy that and it works for you. Just keep going. Gets better. Thanks.